Assalamu alaikum dear students. I am Dr. Shajabeen and today's lecture topic is the continuation of last one, regulation of respiration. And today we will discuss about chemical mechanism for regulation. The chemical factors like carbon dioxide, oxygen and H plus ions influence respiration in such a way that their own blood levels are maintained in the body. This is the ultimate goal of respiration. These are the objectives of this lecture. At the end of the lecture, you would be able to discuss the location, stimulation and effects of central chemoreceptors and peripheral chemoreceptors. Describe what are these chemoreceptors most sensitive to. And you would be able to discuss regulation of respiration during exercise, Cheyne-Stokes respiration, and sleep apnea syndrome. The chemical control of respiration occurs through chemoreceptors. What are chemoreceptors? Chemoreceptors are the sensory nerve endings that are highly sensitive to changes in the partial pressure of carbon dioxide, partial pressure of oxygen, or pH of the blood. There are main two types of chemoreceptors. Number one, central chemoreceptors located centrally in the brainstem medulla, while the peripheral chemoreceptors present peripherally in the body. Let's come to central chemoreceptors. Central chemoreceptors are the group of neurons, also known as chemosensitive neurons, that form a special chemosensitive area beneath the ventral surface of the medulla oblongata of brain stem. Here you can see the yellow colored. These chemosensitive neurons or central chemoreceptors project directly over the respiratory centers. Here you can see the green colored. Which respiratory centers they would be? Yes, medullary respiratory centers located in the same place in the medulla. The chemosensitive neurons of the central chemoreceptor, or you can say chemosensitive area in the medulla, primarily excited or stimulated by hydrogen ions. However, hydrogen ions do not easily cross blood-brain barrier. So the changes in H plus ions or hydrogen ions in the blood have less effect in stimulating these chemosensitive neurons of central chemoreceptors. So, secondarily, carbon dioxide indirectly stimulate the chemosensitive area, and it has a potent, strong effect more than the H plus ions. Why? Because carbon dioxide can easily cross blood-brain barrier. Note that hypoxia, decreased oxygen, or you can say changes in oxygen, do not stimulate these chemoreceptors or the chemosensitive neurons in the central medulla. Now, what is the mechanism by which carbon dioxide affects central chemoreceptors? You can see from this picture, look at here, The blood-brain barrier does not allow H plus ions to cross through readily. Same is the case with the other charged ions too. While carbon dioxide readily crosses the blood-brain barrier. At the below you can see. So, when the carbon dioxide enters into the CSF and the interstitial fluid, it combines with water and will form carbonic acid. That you know, it is an unstable compound and it will dissociate into bicarbonate and H plus ions. Now this H plus ions or hydrogen ion will stimulate the chemosensitive neuron in the central chemoreceptor area, the yellow one. And this is the medulla. So what does it mean? Hydrogen ions are primarily stimulating the central chemoreceptor but not directly. Rather, carbon dioxide entering blood and then dissociate into H plus ions and indirectly stimulating the chemosensitive neurons in the central chemoreceptors of medulla. The stimulation of central chemoreceptors can lead to an increase in respiratory rate and depth of respiration. What is the normal respiratory rate? Yes, 12 to 15 breaths per minute. And it is important to note that 80 to 85% of the respiratory drive, resting respiratory drive, that is 12 to 15 breaths per minute, is due to the stimulatory effect of carbon dioxide on central chemoreceptors. In healthy individuals, the respiratory center is more sensitive to carbon dioxide sensed by central chemoreceptors. This graph shows the quantitative effect of blood partial pressure of carbon dioxide and hydrogen ion concentration on alveolar ventilation. Look at the x-axis, the partial pressure of carbon dioxide in mmHg. What is the normal one? Go to it, the 40 mmHg. You can see there is the normal alveolar ventilation, but when the partial pressure of carbon dioxide increases, there is tremendous increase in the alveolar ventilation too. Look at this red graph. While if you look at the pH graph, pH is negative log of H plus ion. Look at here. Look at the normal levels, that is the 7.3 to 7.4. The changes in pH does not have more effect on the alveolar ventilation. Look at the blue graph. So depicting blood levels of H plus ions have weaker role, while there is a strong role of carbon dioxide in regulating alveolar ventilation. Through central chemoreceptors, as you know, carbon dioxide crosses blood-brain barrier and then dissociate into H plus and drive the respiratory rate, normal respiratory rate, 80 to 85% of it. Peripheral chemoreceptors are the special type of receptors that are located in several areas outside the brain in the periphery. Most of the chemoreceptors, peripheral chemoreceptors, are in carotid bodies or in aortic bodies. Few are located in association with other arteries of thoracic and abdominal region too. Carotid body is located on either side near the bifurcation of common carotid artery. This is the common carotid artery. Look at the picture and at the bifurcation, the blue color one, carotid bodies on either side. While the aortic bodies, may be two or more in number, are located near the arch of aorta. This is the arch of aorta. Aorta coming out, arch, and these blue colored are aortic bodies. This one, 2, and 3. Now, afferent fibers from the carotid bodies, look at here. This is common carotid artery, the bifurcation, the carotid body. Afferent fibers from carotid body join the sinus nerve, or also known as Herring's nerve, a branch of glossopharyngeal nerve, ascends to medulla, dorsal medullary respiratory group, and also the afferent fibers from the aortic bodies. Look at arch of aorta, then aortic bodies. The afferent fibers join the aortic branch of vagus nerve. Look at here, this the vagus nerve, and also ascends to medulla, dorsal medullary respiratory group for stimulation. Now we have done the location of peripheral chemoreceptors and their nerves to medulla. Note one thing, chemoreceptors bodies have multiple highly characteristic glandular-like cells called glomus cells that synapse directly or indirectly with the nerve endings of the afferent nerves we have discussed, that is glossopharyngeal and vagus nerve. But when these receptors are stimulated to send signals through their afferents to the medullary centers, the answer is when the oxygen concentration in the arterial blood falls below normal. The chemoreceptors become strongly stimulated. Do remember, the peripheral chemoreceptors are particularly sensitive to changes in arterial partial pressure of oxygen in the range of 60 mmHg down to 30 mmHg. When the partial pressure of oxygen goes down from 60 to 30, these peripheral chemoreceptors respond strongly. Besides oxygen, that is a strong stimulator for the peripheral chemoreceptors, an increase in either carbon dioxide concentration or hydrogen ion concentration also excites the chemoreceptors. In this way, indirectly increases respiratory activity. As I have told you that afferent impulses from peripheral chemoreceptors ascends to medullary respiratory centers to DRG neurons and lead to an increased rate and depth of respiration. Remember, the peripheral chemoreceptors are the only site that detect changes in partial pressure of oxygen, while Partial pressure of carbon dioxide and H plus ions are detected by peripheral and central, both chemoreceptors. But carbon dioxide and H plus are primarily detected by central chemoreceptors, and peripheral chemoreceptors detect mainly oxygen, low partial pressure of oxygen. How much? Below 60 mmHg. This graph shows the effect of partial pressure of oxygen on alveolar ventilation. When partial pressure of carbon dioxide and the H plus ions are kept normal or kept constant in the normal ranges. This graph shows almost no effect on ventilation when partial pressure of oxygen is greater than 100 mmHg. Look at the x-axis. Here are partial pressure of oxygen and no effect on ventilation here when the partial pressure of oxygen is greater than 100 mmHg. But at the pressures lower than 60 mmHg, look at here, lower than 60 mmHg, ventilation increases many folds. The red graph goes up. This clearly depicts that hypoxia, that is low partial pressure of oxygen in the tissues, strongly stimulate alveolar ventilation. As I have told you before, that in normal healthy person at the sea level, 80 to 85% respiratory drive is by carbon dioxide through central and rest 15 to 20 through peripheral chemoreceptors. But from this graph you can understand that at altitude or due to hypoxia, when partial pressure of oxygen is below 60 mmHg, the partial pressure of oxygen drives the ventilatory process quite strongly. This flow chart is for your revision and shows the effect of oxygen, hydrogen and carbon dioxide, hydrogen ions and carbon dioxide on ventilation. Look here, whenever there is decreased partial pressure of oxygen in the blood, yes, which chemoreceptors are stimulated? Peripheral chemoreceptors are stimulated and they send afferent impulses through herring and the aortic nerve of, these are the branches of glossopharyngeal and vagus nerve, to the dorsal group of neurons DRG in the medulla, that gives efferent impulses to respiratory muscles and increase ventilation. While whenever there is increased partial pressure of carbon dioxide in blood, it will diffuse into the CSF as it can cross the blood-brain barrier easily and form carbonic acid and then dissociate into bicarbonate and H plus ions that stimulate the central chemoreceptor. H plus ions will stimulate the central chemoreceptors. That in turn stimulate again the DRG of medullary respiratory center and send efferent impulses to respiratory muscles and increase ventilation. Now come to the center. Whenever the H plus ions are increased, they cannot cross the blood-brain barrier. So there would be no effect on central chemoreceptor, but they will give mild effect to the stimulation of peripheral chemoreceptors, and also there is mild effect of stimulation from carbon dioxide to the peripheral chemoreceptors, and they will increase the ventilation too. Now, how regulation of respiration occur during exercise? In strenuous exercise, oxygen consumption and carbon dioxide formation can increase as much as 20-fold. But in healthy athletes, alveolar ventilation increases almost in synchronization with the level of oxygen metabolism. And the arterial partial pressure of oxygen, partial pressure of carbon dioxide, and the pH remain almost in the normal ranges. How? Because during exercise, hyperventilation occurs. What is hyperventilation? Hyperventilation is the increase in the rate as well as force and depth of respiration. In moderate exercise, respiratory rate increases to about 30 breaths per minute, and the tidal volume can increase to about 2000 ml. Now the question arises, what causes the hyperventilation during exercise? The answer is brain. Brain, when gives motor impulses for muscles to exercise, also send collateral simultaneous impulses to brain stem to excite respiratory center. Besides, what happens? Afferent impulses from the proprioceptors. What are these? These are the receptors in muscles, tendons, joints. They are also stimulated during change in position of different parts of body during exercise. These afferent impulses stimulate DRG, the medullary neurons, and increase rate and depth of respiration, ventilation. Chemoreceptors are also stimulated by hypercapnia, that is increase carbon dioxide concentration, and send impulses to DRG and increase ventilation. So during exercise, these nervous and chemical signals stimulate receptors and then the respiratory centers, and almost proper and extra oxygen is supplied to the tissues for exercise, and extra carbon dioxide is blown off. Now some of the applied aspects. What is periodic breathing? Periodic breathing is characterized by alternate periods of respiratory activity and apnea. What is apnea? Apnea is the temporary cessation of breathing. One of the periodic breathing is Cheyne-Stokes respiration, in which there is alternate periods of respiratory activity and then apnea occur, and that all occurs at regular intervals during the 1 minute of the respiratory activity. You can see in the picture there is gradual increase in the force of respiration and then gradual decrease. This is known as waxing and waning. Then there is temporary cessation of breathing, that is apnea. Afterwards, again increase activity, and all this occur at the regular intervals, and this type of periodic breathing is known as Cheyne-Stokes breathing. These are the causes of Cheyne-Stokes respiration: physiologically voluntary hyperventilation or at higher altitudes, while pathological causes are chronic heart failure, brain damage, or poisoning by narcotics. Whatever may be the cause, the basic mechanism is increased sensitivity of central chemoreceptors due to the increased carbon dioxide in the blood. Increased partial pressure of carbon dioxide in the blood. That partial pressure of carbon dioxide in the blood causes increased respiratory activity through the DRG and hyperventilation. Now, due to prolonged hyperventilation, carbon dioxide washes out from the body, or there is excess blowout of carbon dioxide from the body, which in turn causes apnea. That causes again accumulation of carbon dioxide, and again there is hyperventilation. So there is the cycle of hyperactivity of the breathing, then apnea, then hyperactivity. This is Cheyne-Stokes respiration. Sleep apnea syndrome includes apneic episodes. Apneic means temporary cessation of breathing for seconds during sleeping. All the patients or individuals with this syndrome usually have daytime drowsiness, tiredness, and other disorders like hypertension and cardiovascular diseases. Obstructive type of sleep apnea occurs, as the name says, there is obstruction in the airway. Look at the picture. This is a normal one when there is no obstruction in the airway. While look at this picture, in the sleep apnea, there is blocked airway. That may be in older or obese persons having fat deposition in soft tissue of pharynx that compresses it, or any obstruction due to enlarged tongue, tonsils, or certain shapes of palates that increases airflow resistance or block airway. Partial airway obstruction may cause sometimes snoring as well. The association of sleep apnea with extreme overweight or obesity is referred to as Pickwickian syndrome, in which overweight people fail to breathe properly and have low levels of oxygen or increased level of carbon dioxide in their blood and constant tiredness. Another type of sleep apnea is central sleep apnea. It is also known as non-obstructive sleep apnea. In this sleep apnea, there is transient stoppage of rhythmic activity from the respiratory centers, medullary respiratory centers, and the cause may be damage to the central respiratory centers or the abnormalities of the respiratory neuromuscular apparatus. For example, in stroke, it happens. For treatment, surgery is done for the removal of extra or excess fat tissue at the back of the throat. This is a procedure that is known as uvulopalatopharyngoplasty, in which enlarged tonsils or adenoids are removed. Or sometimes tracheostomy is done, that in which there is opening in the trachea is made to bypass the obstructive airway during sleep. Sometimes patients are advised to take nasal ventilation with continuous positive airway pressure, that is known as CPAP. In the picture, you can see there is nasal ventilation with continuous positive airway pressure. This one. Thank you, students. This is my email address for your queries and the reference books names.